Welcome everyone to our third QA Forum of 2023. I'm Dr. Michael Novick, the Director of Education and Associate Director of Quality Assurance for vRad. In this forum, we'll be discussing some GI and GU cases. Here is our accreditation statement for your review, as well as the learning objectives for this lecture. Let's jump right into our first patient. This is a 92-year-old man with gastrointestinal bleeding. We'll begin by scrolling through the axial images from a non-contrast CT scan of the abdomen and pelvis. Moving on now to the axial images from a CT angiogram of the abdomen and pelvis. Recall the importance of reviewing both the pre- and post-contrast images, including any delayed images if they're available in cases of potential GI bleeding. Speaking of the devil, here are some more delayed axial images. Returning now to one of our delayed axial images, we can see a faint focus of contrast blushing in the dependent portion of the sigmoid colon. It's crucial that we return to the arterial phase and non-contrast images to scrutinize that area and confirm true GI bleeding. And we can clearly see that focus of hyperattenuation is essentially absent on the arterial phase images, as well as the non-contrast images. So our diagnosis in this case is, of course, an acute lower GI bleed. It's very important to work systematically in these cases. I tend to begin with the delayed images where the bleeds are most conspicuous and work backwards from there. Your mileage may vary. Our next patient is a 75-year-old man with chest wall pain. Let's begin by scrolling through these axial images from a non-contrast CT scan of the chest. Reviewing this single slice at the level of the lower chest, we can see dilatation of the distal esophagus with associated irregular wall thickening. A bit more inferiorly at the level of the upper abdomen, we can see a stent at the level of the gastric fundus. Let's quickly scroll through these axial images from a prior contrast-enhanced CT scan of the abdomen and pelvis. We'll limit our search to the upper abdomen and lower chest. On the left side of your screen, we have a single coronal image from the current non-contrast study, which demonstrates the stent at the level of the gastric fundus. On the right side of your screen is a single coronal image from the prior study, which demonstrates the stent at the level of the distal esophagus. So this is an example of esophageal stent migration, which demonstrates the importance of always reviewing any prior imaging that's available. Our next patient is a 78-year-old man with vascular insufficiency and abdominal pain. We'll begin by scrolling through these axial images from a contrast-enhanced CT scan of the abdomen and pelvis. Here are the coronal images from the same study. Let's review our findings. Here is a single axial slice at the level of the mid-abdomen, which demonstrates a blind-ending, somewhat inflamed tubular structure arising from the distal ileum. There is some infiltration of the adjacent mesenteric fat. On this coronal slice, we can better appreciate the tubular nature of the finding. And again, the subtle adjacent inflammatory change. So this is a case of Meckel's diverticulitis. Let's just quickly review some of the features of Meckel's diverticulitis. We all recall the rule of twos. It affects 2% of the population. Meckel's diverticula are typically approximately 2 inches long, and they live approximately 2 feet from the ileocecal valve. They contain two types of ectopic mucosa, both gastric and pancreatic, the gastric mucosa being the reason for increased activity on technetium-99 pertechnetate scans. And finally, they most commonly present in patients approximately 2 years of age. While Meckel's diverticula appear with equal frequency among men and women, symptomatic cases of diverticulitis are more common in men. They typically present with right lower quadrant pain, so can mimic appendicitis, and painless rectal bleeding can occur due to the presence of ectopic gastric mucosa. And as I mentioned, technetium-99 pertechnetate scans are sometimes deployed to confirm the diagnosis. This AJR article provides a good overview if you're looking for some more information on the subject. Let's move on to our next case. This is a 56-year-old woman with a history of chronic cholecystitis presenting with worsening abdominal pain and nausea. These are axial images from a non-contrast CT scan of the abdomen and pelvis. The coronal images from the same study. Let's discuss the findings, beginning with this axial slice at the level of the upper abdomen, which demonstrates pneumobilia. A bit more inferiorly, we can see evidence of the patient's known chronic cholecystitis. There are gallstones with associated inflammatory change. More inferiorly still, there are multiple dilated loops of small bowel with air fluid levels. With intraluminal stones and fecalization in the region of the transition. Returning to the right upper quadrant on this coronal image, we can actually visualize direct erosion of the inflamed gallbladder into the duodenum. This single coronal slice demonstrates many of the findings beautifully. The pneumobilia, the dilated loops of small bowel, and the calculi at the transition point. So this is a classic case of gallstone ileus. Both the clinical history and the imaging findings are typical for this entity. Let's wrap things up with one final case. This is a 32-year-old woman with hematuria. These are axial images from a contrast-enhanced CT scan of the abdomen and pelvis. The delayed images from the same study. And finally, the coronal reformats from that same delayed series. Let's begin our review with this single slice at the level of the lower pelvis. There is very subtle urothelial thickening and enhancement at the level of the UVJ. There are irregular linear filling defects in the distal ureter. There is also lobular soft tissue projecting into the urinary bladder. This finding is visible on all the images, however, it is brought into much sharper relief by the presence of contrast in the urinary bladder on the delayed images. It's easy to see on this coronal image how one might miss the findings without the delayed images. The urothelial thickening and enhancement is rather difficult to see. However, the delayed images make it more difficult to miss the intraluminal filling defects in the distal ureter, as well as the soft tissue mass projecting into the urinary bladder. So this is a distal ureteral mass with the leading diagnostic consideration being transitional cell carcinoma. This patient ultimately underwent a contrast-enhanced MRI of the abdomen and pelvis, which nicely delineates the distal ureteral urothelial thickening and enhancement. along with the soft tissue component extending into the urinary bladder. Thank you so much for joining me. I hope this was useful for you, and I will be back shortly with the fourth QA Forum of 2023. I look forward to seeing you all there. Thanks again.